This is an educational update from the Advanced Imaging Technology Department of Majestic 12. Please remember that the information provided is for your eyes only. Welcome to this clinical reference video on MRI of the vagina, covering protocol optimization and diagnostic pathology. Our protocol is simple. Prepare 60 milliliters of bacteriostatic surgical lubricant. Insert the gel with a Yankauer tip and image while the patient avoids the Valsalva maneuver. The gel acts as a T1/T2 contrast agent and helps separate walls, define the exocervix, and detect microinvasions. The core diagnostic sequence is T2-weighted FSE/TSE, the exam's workhorse, requiring high-resolution, small field-of-view images. T1-weighted is useful for hemorrhage and fat, while diffusion-weighted imaging is vital for oncology cases to identify high cellularity. Gel distension transforms a collapsed potential space into a readable structure. This is essential for distinguishing the cervix from the vaginal fornix and differentiating anterior from posterior wall lesions. This matrix compares key congenital anomalies. Note the underlying defects and characteristic MRI findings, such as the fibrous band in transverse septum, or the absence of the uterus in MRKH syndrome. Here we see images of a vaginal septum, clearly demonstrated using the vaginal gel technique. The technique helps visualize the anatomy more clearly. Common vaginal cysts include the Gartner duct cyst from the mesonephric duct remnant, the Skene gland cyst, which is a prostate equivalent, and the Bartholin gland cyst from the urogenital sinus. Gartner's duct cysts are remnants of the Wolffian duct. These axial and coronal T2-weighted MRI images illustrate a typical presentation of this type of cyst. Deep pelvic endometriosis shows low-signal fibrosis intermingled with high-signal hemorrhagic foci on T1/T2. Giant condyloma acuminatum presents as aggressive, cauliflower-like verrucous lesions, often recurring and carrying a high risk of malignant transformation to squamous cell carcinoma. Primary vaginal neoplasms are rare. Squamous cell carcinoma makes up 85% of cases and is typically staged based on invasion depth, from limited to the wall up to adjacent organ involvement or distant spread. Vaginal melanoma is hypervascular and shows diffusion restriction. Secondary vaginal neoplasms represent 80% of all vaginal tumors. They can arise from direct dissemination from the cervix and rectum, or via lymphatic/hematogenous spread from the endometrium or ovary. These images show cervical cancer invading the upper vagina and rectovaginal septum. The arrows highlight the extent of the tumor invasion. We observe examples of vesicovaginal and rectovaginal fistulas, as well as vaginal stenosis. Vaginal stenosis is a late complication of radiotherapy, caused by progressive, obliterating endarteritis. Dynamic MRI is crucial for assessing pelvic floor prolapse, which results from the weakening of suspension structures. It assesses the exact degree of multi-compartment prolapse to guide surgical reconstruction, comparing resting state with the Valsalva maneuver. The gel protocol is rapid and low cost, using just 60 milliliters of Surgilube and a Yankauer catheter. It enables clear differentiation of the cervix from the vaginal fornices and defines the anterior and posterior vaginal walls. Vaginal distension is a necessity for accurate female pelvic MRI. Thank you for participating in this educational video. Please remember to submit your online non-disclosure agreement within the next 24 hours.